as mentioned, I'm going to be talking about updates in WHO classification, including differential diagnoses and pointing out some pitfalls. I have no disclosures related to renal tumors. And this is what I'm going to be talking a little bit about today, and why I like kidney tumors so much. For one, they're just fun. I always say kidney tumors rock. As I've mentioned, there's been many recent updates and changes in the WHO, so it's a fast moving topic that allows for updated lectures from time to time. The differential diagnoses of renal oncocytic tumors is one that's been growing probably the fastest, and I think it's important that we're all aware of these new entities. And again, as Paco mentioned, there's so much morphologic overlap between these renal tumor subtypes that it's important that you distinguish one from the other, because they really have different prognoses associated with them and can be affiliated with different treatment options. And we'll talk about some of these. The lecture objectives were outlined to you already, so I'll pass over those and just get started. So renal cell carcinoma, as you likely know, is a heterogeneous group of carcinomas. When they are perfect by H&E morphology, you could probably make the diagnosis of many of them by H&E alone. And I do believe in being a morphologist first, but there is significant overlap in these tumor types, which do require ancillary studies from time to time in a good number of cases, and more so lately because of this expanding WHO classification. So there's been multiple modalities that has allowed for this expansion, as simple as immunohistochemistry, fluorescent in situ hybridization, next-gen sequencing. And thankfully, it's been really helpful, the fact that renal cell carcinoma is one of the fewer carcinomas that shows recurrent copy number alterations. And that's been really helpful for us as well. So this is just an overview, a 10,000-foot overview of the WHO classification changes over the past 2 decades. We started, of course, with just 4 real carcinomas, epithelial tumors in the kidney, that expanded in 2004, and even more so to almost a couple dozen tumor types in 2016. So this kind of brings up this sort of food for thought that I always sort of think about and talk about, is the idea of splitting versus lumping. Because certainly lots of people can have different ideas about whether or not we should be splitting these tumors into individual entities or lumping them together, sort of like was seen here back in the early 2000s. The first and second edition of the WHO was more lumping things together. And now, as we've moved progressively, of course, we split them apart. There's pros and cons for lumping. Of course, pros for lumping is it makes it easier to diagnose. You need fewer ancillary studies, and it may not actually significantly alter treatment options. The majority, albeit not all, of the clinical trials that are out there are basically lumping tumors into a clear cell renal cell trials and non-clear cell renal cell trials. And so really, if you just lump them together, as long as you exclude clear cell renal cell carcinoma, it may not make a difference. But as we start to identify more and more tumor types, specific clinical trials are being designed for specific tumor types. So, oh God, it says pros on both. Oh, pros for splitting. To demonstrate the pros for splitting, of course, is to demonstrate true pathologic differences, to have a better understanding of the pathophysiology of these individual tumor types, and as mentioned, to direct treatment options and perform clinical trial design. And as we'll see today, this can also have a really big impact on tumors with familial associations and genetic testing. So here's just a general concept of that. If you're a lumper and these are 2 tumors, both would be just called clear cell renal cell carcinoma. But the truth is, the one on the left is a clear cell renal cell carcinoma, and the one on the right is a translocation renal cell carcinoma. And by morphology alone, there would be absolutely no way to distinguish these two unless you think about the possibility of a translocation and use ancillary studies. So this is the concept of being a splitter. And this is just, you can split by morphology, but you can also use some different parameters, architecture, staining profile, tumor location. Is it a medullary versus a cortical-based tumor? So you can use lots of ways to lump things together. And then under that lumped category, there are multiple tumor types that you could split apart. And of course, I'm talking about this in context with kidneys today, but certainly this could be, same sort of concept could be applied to any organ system within the body. So I like to think better of being a discrete lumper or a discrete splitter. I liked this idea of being a slumper, and that's to sort of take things and again, really consider breaking these tumors apart based on pathophysiology, maybe not going too far and breaking up more than is absolutely necessary, but to sort of take them in context, split them apart where is needed, and design and get a better understanding of these individual tumor types. Okay, so having said that, using this concept of slumping or splitting tumors apart, this is where the WHO classification has recently ended up. In March of this year, the 5th edition of the WHO came out, and this is an overview of the breakdown for renal epithelial tumors. And I should clarify, this is for adults, renal epithelial tumors in adults. And one of the things that's been different here is you can see that they've broken them down into subcategories, including this molecularly defined renal cell carcinoma category, which we'll be talking about some of these entities today. So the next 3 slides are really going to be the summary of the entire talk. And for the take-home message, these are the WHO updates in kidney pathology in this new 2022 edition. The major updates includes the reorganization of tumor types, as I just pointed out on the last slide, including categories such as molecular defined tumors and other renal tumor subtypes. One renal cell carcinoma has been downgraded from a carcinoma to a benign neoplasm. There were 3 carcinomas that were previously in the emerging group of tumors that are now included in the classification of RCCs. And it has now been that it's officially removed the type 1, type 2 designation for papillary RCC, which should no longer be used. The minor updates in the WHO includes the fact that there's still a growing set of emerging entities that are being worked on. This includes tumors in the other oncocytic tumor of kidney category, and also includes multiple subtypes that are thought to be under the heading of papillary renal cell carcinoma. In this classification scheme, they've changed the word RCC unclassified to not otherwise specified. Frankly, I'm not really sure why. What I can tell you is we're not going to talk about this much more today, but I can tell you that I use RCC unclassified for high-grade tumors that I'm unable to diagnose specifically, and I use NOS for low-grade tumors that I'm unable to diagnose specifically. And then lastly, it's been officially changed. HLRCC associated RCC, which was the name of these tumors in the 2016 edition, has now been officially changed to fumarate hydratase deficient renal cell carcinoma, because not all of these tumors are associated with HLRCC syndrome. Unresolved issues includes grading of specific renal cell carcinomas. An example of that is Furman or WHO grading is not used for chromophobe renal cell carcinoma, but it's unclear whether we should or shouldn't be grading some of the new subtypes of tumors. And then, of course, still working on some of these emerging entities. So that's the overview. Here is a list of the emerging entities that potentially could be in the next WHO for the 6th edition, but these are just names that you could sort of look at, sort of see for familiarization, just to know they're out there. We'll be talking about LOTS and EVTs today. And of course, I won't be able to talk about every one of these entities in detail. So here are 2 recent manuscripts for your reference. One paper, these are both put out by the GUP Society, and one paper describes existing entities and one with emerging entities. These were published before the WHO came out, but basically everything you would need to know is in these papers. All right, let's talk about update number 1. And this is the downgrading of the tumor clear cell tubulopapillary renal cell carcinoma down to a benign tumor and is no longer designated as carcinoma. So clear cell tubulopapillary tumor, as it's now referred to, is a tumor that is synonymous with clear cell papillary tumor. I never use clear cell papillary because I think it's confusing between clear cell and papillary RCCs. These tumors are often and almost exclusively tubular in some component. So we put the word tubulo, and both of these terms are in the WHO. They are synonymous, but I'm a big advocate for using clear cell tubulopapillary now, especially that these tumors are benign, to make that very distinct from clear cell and papillary renal cell carcinomas. And this is, of course, what these tumors were previously misdiagnosed before these were identified, approximately in around 2007, 2008. It actually has now become the 4th most common renal cell tumor subtype. And if you look for it, you will see it not infrequently in your, and if you think about it, in your cases that come across your desk. It was first identified with associated with end-stage kidney disease, but it can be seen quite frequently in sporadic kidneys as well. They are often small, well circumscribed, have low-grade nuclei, and that's all associated with a favorable outcome. There have been hundreds of cases reported in the literature with basically no recurrences, no metastases, which is why they are now considered a benign entity, which is important for patients so they don't have as much follow-up, and they maybe could be followed and not even require surgery. This is what they look like. They're often well circumscribed, small. They can be solid. They can be cystic. This one had hundreds of them. Every single was a clear cell tubulopapillary. They can be multifocal. But they pretty much show pretty unique cytomorphology. I see them, what I describe, in two major patterns. One is the picket fence, where you see very bland low-grade nuclei along the basal portion of the cell here, forming a picket fence, and then this checkerboard pattern where you have sort of what I call black white areas, and these dense areas in between are all actually tubules that are just very condensed together to form what looks like a solid component, and then you have these tubular structures. They can also be cystic, papillary, have hyalinized stroma. These are common findings, and they can be associated with a fibromuscular stroma. There was an entity called renal angiomyoadenomatous tumors, previously diagnosed and described in the literature, and rats are part of the clear cell tubulopapillary family, and they just have more fibromyomatous stroma associated with these tubular structures. Now, the most common distinction that needs to be made is with a clear cell renal cell carcinoma. We're all familiar with this, and they often have lack of 7, diffuse CA9, CD10 expression, and of course, the hallmark is the loss of 3P or mutation on the VHL gene. But they often have clear cell features, of course. They can be low to high-grade nuclei, and they should be distinguished from a clear cell tubulopapillary. Thankfully, the immunoprofile for clear cell tubulopapillary tumors is basically the exact opposite. They are strong and diffuse for CK7. They are dead negative, no Amicar in these tumors at all. They can have negative or focal CD10, and they also express CA9, but they express it in a different way. Whereas clear cell renal cell carcinoma has a box-like pattern, these have a cup-like pattern. And you can see that here at high power, where you get all areas of the cell is staining with CA9 in a clear cell, and you get the lateral and basal portion of the cell is staining with CA9 in a clear cell tubulopapillary, and the apical portion is negative. That's really, really helpful. This same small panel of immunomarkers can actually help you with other tumors in the differential, such as papillary, translocation, and ELOC-RCCs, which we'll talk about in a minute. All these tumors can be split apart by morphology, immuno, and cytogenetics, as they have different, as can be shown here. Now, here's the first pitfall for you. What you have to be careful about is that some clear cell renal cell carcinomas can have a tubular component. If you look at this, this is one case. And if you look at this image on the left-hand side, you can see low-grade nuclei in a picket fence-like arrangement, slightly tubular architecture. Here it is again, maybe what I call slightly broken fence, which may think you think it's not perfect for a clear cell tubulopapillary, and you should always just go look for more conventional nested alveolar-like areas to think about a clear cell. But if you're not sure, or maybe you're dealing with a core biopsy, using CK7 and CA9 alone should be helpful. And despite the tubular component in this particular case, it was absent for 7, box-like CA9, consistent with a clear cell, not a clear cell tubulopapillary tumor. Now, as mentioned, these have been downgraded to a benign entity. This is just what Kaplan-Meier curve. You can barely see the blue line at the top because they're so well behaved. It's basically a straight line. And that, again, leads to its benignity. All right, update number 2. So, unfortunately, the tumors we're talking about today are definitely on the rare side, but mostly what I want is for you to recognize, because these are showing up on my bench more and more. I always say, if you don't think about it, you won't diagnose it. And I think about these all the time, so I'm seeing them actually quite more frequently. But I want to explain to you so that you're ready for the 3 new entities that have been added to the WHO. The first is called TSEB, or ELOC-mutated renal cell carcinoma. It was first described by Memorial and by me actually in 2015. Memorial looked at it and found them from the molecular side of view, where they found the TSEB mutation in the TCGA subset of tumors. I was looking at cytogenetics of cases and found a bunch of tumors that looked like clear cell renal cell carcinomas, but had intact 3P and monosomy 8. And that's what's required molecularly for this diagnosis. Biallelic inactivation of TSEB and an intact VHL mutation. It's a pretty rare tumor. There's only about 30 in the literature. The majority of them are thought to be indolent or benign, but rare cases have been shown to metastasize. This is what they look like, and you can see there's morphologic overlap with clear cell and clear cell tubulopapillary tumors. Clear cell cytology, lined up nuclei, solid growth. You can have papillary architecture, cystic formation. So they can be a little bit heterogeneous, but they all have a relatively low grade lined up nuclei and this clear cell features. What's really classic in these tumors is they have a very, very thick fibrous capsule that you can see here. And again, characteristically, they have these dissecting fibromyomatous bands. So those I see in basically every case. The differential diagnosis includes clear cell renal cell carcinoma, translocations, the clear cell tubulopapillary tumors, and because of the fibromyomatous stroma, these previously referred to rats, same family. And then again, this idea of renal cell carcinoma with fibromyomatous stroma, which is not a discrete entity in the WHO. Now, again, if we basically use that same panel of immunostains, we can support the diagnosis, but it's not as definitive as was with clear cell tubulopapillary. These tumors are also diffusely CK7 positive, which argues against a clear cell. They have pachydiofocal Amicar, pachydiofocal CD10, and they are strong and diffuse for CA9 as well in a box-like pattern. So that's going to argue against a clear cell tubulopapillary, but could be confusing with a clear cell renal cell carcinoma. It's the strong and diffuse CK7 that is helpful. But truthfully, if you really want to make a diagnosis of TSEB-mutated renal cell carcinoma at this time, it should require molecular confirmation, which can be done with fluorescent in situ hybridization. I usually use SNP microarray to make this diagnosis if I'm considering it. The real reason is because they are low-grade indolent, but they still typically come out because they have a designation of carcinoma. Now, I just want to step back and mention this idea or this concept of renal cell tumors with fibromyomatous stroma. It's coming up in the literature more and more. There are multiple tumor types that have fibromyomatous stroma, some of which, and where they first were described, was in a patient with TSC, a familial TSC patient. But really, they can be seen. Raj Shah did a study, and there's been a couple other papers where they look at tumors that have clear cell cytology and fibromyomatous stroma. Some of these can actually have 3P loss and are clear cell renal cell carcinomas. Some are clear cell tubulopapillary renal cell tumors. Some are TSEB or ELOC-mutated renal cell carcinomas. And some are none of these three, but have a TSC or mTOR mutation in the sporadic setting. So basically, in my opinion, these should not be a top-line diagnosis. The fibromyomatous stroma can be diagnosed or mentioned in a note if you would like, but really you should take and make the effort to exclude the other entities. And if you can't get to a discrete entity, call it a renal cell carcinoma not otherwise specified with fibromyomatous stroma. Okay, moving on to the second tumor that's been added to the WHO classification, and that's an ALK-translocated renal cell carcinoma. These are extremely rare and occur more frequently in children than they do in adults. So because we don't have a children's hospital here, it's separate anyway from the Brigham and Women's Hospital, I don't see these very often, but I'm always on the lookout. In children, they occur with sickle cell trait, and they have a very specific VCL ALK translocation, which is different in adults who don't have sickle cell trait and have a non-VCL transfusion partner, still with ALK, but it could be one of many translocation partners. In children, there's consistent morphology for the VCL ALK translocations. And again, the presence of sickle cells could be a big clue for you. It's typically solid growth, eosinophilic cytoplasm, vacuoles, and a lot of a lymphocytic infiltrate. Unfortunately, in the adults, it's very, very variable morphology. So you can see solid growth, nests, papillary architecture, etc. They often still have eosinophilic cytoplasm, but the morphology is not nearly as specific. This happens to be images from a child who has sickle cell. So again, when I have sort of a high grade or what looks like at first an unclassifiable tumor. I always go look at the blood, and if I find sickle cell, that's a clue for me to think about ALK-translocated or renal medullary carcinoma. And again, vacuoles, pink cytoplasm, solid growth. This one was intact for INI1, ruling out renal medullary carcinoma, and had an ALK-translocation. This is images from a paper by Kirill Tripkov showing ALK-translocated RCC in an adult. And you can see here there's very heterogeneous morphology, including eosinophilic cytology, papillary architecture, cystic change. But basically, when you see this again, it would be sickle cell negative, so round red blood cells looking for diffuse ALK expression, and or the ALK translocation would be confirmatory. The remainder of the biomarkers are non-specific, but basically you do want to exclude other entities, for example, INI1, which would be lost in a renal medullary carcinoma. This is the differential diagnosis for ALK-translocated tumors. It includes papillary RCC, collecting duct carcinoma, FH deficient renal cell carcinomas, the SMARC1 deficient renal cell carcinomas, including renal medullary carcinoma, and a subset of unclassified RCCs. Here's just as an example, these are two SMARC1 deficient renal cell carcinomas, and I will mention that in the WHO classification, these fall under the molecular defined renal cell carcinomas, so they're within that category. I still call it renal medullary carcinoma and put SMARC1 deficient in parentheses next to it, but eosinophilic solid growth here in the renal medullary carcinoma, again, you can see sickle cells and a loss of INI1. In the unclassified RCC with medullary features, you will not have sickle cell trait, but you still have loss of INI1 by morphology, by immunohistochemistry, confirming the diagnosis of a SMARC1 deficient RCC. This unclassified RCC is much more common in adults, and renal medullary carcinoma, of course, is also much more common in children. Okay, so why is it important to distinguish these ALK-translocated renal cell carcinomas from other subtypes? Well, the majority are indolent, but up to a quarter of them can have malignant behavior. And as you probably all know, there are ALK inhibitors out there which can be useful in these types of cases. This is a case report of one here showing a study showing 3 different patients where you got shrinkage of the tumor, the kidney tumor, using an ALK1 inhibitor. So it's really important to distinguish this tumor from other tumor types. Again, the ALK immunostain is your first, and INI1 would be your first sort of screening tools, but really important to distinguish from other tumors, especially papillary renal cell carcinoma. All right, the third entity has been added into the WHO classification is the eosinophilic solid and cystic renal cell carcinoma. This was described first by Kirill Tripkov, who's up in Calgary, and it is in the other renal tumor category classification within the WHO. It represents fewer than 1% of renal cell carcinomas, and there's about 60 in the literature. But I'll tell you, I diagnose these not frequently, but I'll see a few of them a year, and they come across my bench, and they're certainly in the differential diagnosis for a lot of pink tumors that we're seeing lately. They're typically small, they're most frequently well-behaved, and the big clue about these is they are one of the tumors that is almost exclusively seen in women. So as soon as I see woman as a gender on my piece of paper, I'm thinking things like ESC and translocation renal cell carcinoma right off the bat, even before I see a slide, because these occur so frequently in women. Then if you look at the slide down the microscope, what we're looking for is exactly as the name, a tumor that's eosinophilic, solid, and cystic. So the name is, of course, very, very descriptive for what you're seeing down the microscope. But there are other features to look for. Here you can see they can have macrocysts or microcystic spaces. Again, solid and eosinophilic areas. You can see some clear cell or vacuolated cytoplasm, and that can be variable and heterogeneous throughout the tumor. This is a case that I diagnosed on a core biopsy. You can actually see the cyst lining here and the eosinophilic solid component below. And in fact, this partial nephrectomy on the slide before is the partial nephrectomy that came after this core biopsy. Again, I mentioned predominantly eosinophilic cytology, but you can have variable clear cell components. And then one of the most reproducible features, although not entirely specific, is this basophilic stippling. You can see these little blue blobs within the cytoplasm. Basophilic stippling is seen quite frequently in eosinophilic solid and cystic RCC. You can see it in the solid component. You can see it here stippling in the cis lining. And this was a case that came to me. The entire tumor had been frozen at frozen section because it was so small. And I'll tell you, I struggled for a while because it wasn't good, hadn't fixed well. And then I noticed that it had this basophilic stippling, even though it was frozen tissue, and that helped me with the diagnosis. The differential diagnosis, of course, I already mentioned, just because female patients would be translocation RCC, some of which can show eosinophilic cytology, SDH deficient RCCs, which we're not really going to talk much about today, but they are, of course, solid eosinophilic tumors, FH deficient RCCs, eosinophilic vacuolated tumors, which we'll talk about in a few minutes, and pecomas, which are a non-epithelial tumor of the kidney that have lots of pink and clear cytoplasm. So like most tumors, can we use immunostains to make this distinction? Well, we can. They're not entirely specific, but they can be used to help support the diagnosis, as well as exclude other entities. CK7 is usually focal or variable, but not diffuse. KIT should be negative. Amicar is variable. CD10 is positive, which would be different than, say, like an oncocytoma or a chromophobe. Intact staining for SDH and FH would be positive to exclude those. And Vimentin, again, would be negative in renal oncocytomas or chromophobe. So this is really not entirely specific, but helps exclude other entities. The two markers that are most frequently used to support the diagnosis of an ESC is CK20 and potentially cathepsin K if you have it. So these have one of the very few, if the only renal cell tumor that we know about that really has uniform or reproducible CK20 expression. I almost never order CK20 in kidneys unless this is in my differential. They can also be focal diffusely positive for cathepsin K. This is a single case showing CK20 expression that can be very heterogeneous in different areas of the tumor, which I had stained for research purposes, but you can see that the CK20 can be focal, patchy, or diffuse to make this diagnosis, or at least support this diagnosis. Now, the molecular for ESCs is relatively distinct in that it helps exclude it from, say, a renal oncocytoma or a chromophobe, but has a TSC mutation, which we'll talk about more in a little bit, which is non-specific overall, because more and more tumors are showing up to have TSC mutations, but these have very reproducibly been shown to have somatic biallele TSC1 and TSC2 mutations. This is one study done by Pete Argani on the right side, showing multiple cases and where their mutation was. There's also been some distinct chromosomal copy number changes that have been reported, showing that these are distinct tumors from other entities and have been split apart and included in our WHO classification. As I mentioned earlier, these are predominantly small, well-circumscribed and indolent, but about 5 to 10% have been shown to have aggressive behavior. All right, moving on to the third WHO update that I'm going to be talking about, and this is the concept of eliminating the type 1, type 2 papillary renal cell carcinoma designation. Now, I don't know if your institution ever has done this. Many have. Here at the Brigham, we have absolutely never used type 1, type 2 classification of papillary renal cell carcinomas. It's really just been a big black box, and that's how we've looked at it for many years. For the older pathologists in the crowd, I think of type 1, type 2 as the MFH of renal cell carcinomas. The younger pathologists might not understand that as much. But anyway, type 1, type 2 has been eliminated. If you think it's a papillary renal cell carcinoma, just call it, give the grade, give the stage. That's all that's needed. Okay, but why has it been eliminated? Well, there were certain features that were used back in the WHO in 2004 to distinguish these two types. And basically, type 1s were lower grade, small basophilic cells, a single layer, yada, yada, CK7 and Amicar positive, whereas the type 2s had larger cells, eosinophilia, pseudostratified cells, et cetera, and were, higher grade. Many of them were CK7 negative. The problem is there are tumors out there, and I'm sure you've all seen them, that have overlapping features between type 1 and type 2. Here is an example where you have a single cell layer, which would be type 1, of pink cells, which would be type 2. So what do you call an entity like that? And for that is one of the many reasons, because tumors can have overlapping features between type 1, type 2, that it has been eliminated. Here is one example of tumors that have been out from the type 1, type 2 classification. And this was a pink papillary tumor with a single cell layer. These are papillary renal cell neoplasms with reverse polarity. There have been multiple studies. Dr. Al-Obeidi has been really, he calls this his baby. This tumor type is his baby because he's described it. And basically, these tumors have variable amounts of Amicar, which is unlike papillary renal cell carcinoma. They are almost universally express GATA3. And I do think this is a very supportive biomarker for this tumor type, but I would be because GATA3 is being shown in the literature to stain numerous renal cell tumor types. And I think you should always take the staining with a grain of salt. But if you have a low-grade pink tumor and the nuclei are on the apical portion of the cells, and you have GATA3 expression, that is very supportive of this papillary renal cell neoplasm with reverse polarity, one of the tumors in the emerging entity category. The other thing that Dr. Al-Obeidi has shown that these tumors recurrently have KRAS mutations. Here's more evidence not to type papillary renal cell carcinoma. This study came out of Yale. I love it. They took tumors that were type 1, type 2, and mixed, and they looked at prognosis and outcome based on whether it was type 1 or type 2. And compared to that, if you looked at just grade, stage, size, and architecture, and there was no significant difference statistically between type 1s and type 2s, or those that were mixed, but they did have statistical significance in disease-free survival, overall survival, if you looked at grade, stage, size, and architecture. So that's all you need in your report. Type 1, type 2 is not really providing the clinicians with any additional information. The biggest reason for removing type 2 papillary renal cell carcinoma is, as I said, it's the MFH of renal cell carcinomas. It is a heterogeneous group of tumors with overlapping morphologic findings, which have distinct genetic and molecular alterations. And of course, this is all very different from 2004 when type 1, type 2 was introduced, because we now have molecular tools that help us tease apart these renal cancer subtypes. Now, I'm not going to have time to talk about all these today. We've already talked about ALK-translocated renal cell carcinoma, which is in the differential of a papillary renal cell carcinoma and should always be excluded when needed. And the one we're going to talk about mostly is FH-deficient RCC. So here's just by example 2 cases. Both have papillary architecture, both have high-grade cytology, both have cystic formation. And in the old days, these would both be called papillary renal cell carcinoma. But if you use some ancillary studies, in this particular case, FH antibody, which we look for loss of staining to make the diagnosis of an FH deficient RCC, as seen on the top, confirming the diagnosis, is intact in the bottom, and this tumor had a trisomy 717. So despite the fact that they're both papillary, and in the old days would have both been called so-called type 2 papillary RCC, they are discrete and different entities. So what is FH deficient RCC? It is a high-grade tumor most of the time, and we'll get back to that, which is part of the HLRCC, or hereditary leiomyomatosis and renal cancer syndrome. It is associated when the familial situation with autosomal dominant inheritance that can be passed on to family members, associated with smooth muscle tumors and renal cell carcinomas that are very, very aggressive. In 2016, these were called HLRCC syndrome-associated RCC. But the problem with that name, of course, is that you don't know when you're making the diagnosis if the patient has germline mutation or if it's a somatic malignancy. So in this WHO, everyone agreed that it's better referred to as FH deficient RCC. And then the patient will get for germline testing to determine if it's familial or somatic. Here's some examples. They can be small, they can be large, they are solid, cystic, white, fleshy tumors that, again, predominantly are very high grade and aggressive. They can be, as mentioned, solid. They can have vacuole formation in the cytology. They typically almost always have some kind of cyst formation, and that's a clue to me when I'm looking at these tumor types. If there's cyst formation as well as papillary architecture, I think about FH deficient RCC. And of course, as you probably know, they have pretty characteristic, what we call CMV-like nuclei, where you have these very, very, very large cherry red nucleoli and perinucleolar halos, And these can be seen scattered in leiomyomas, although not nearly as prominent as well. So we start to look for high-grade tumors, papillary architecture, cystic formation, and this kind of cytology. You should definitely be thinking about an FH deficient RCC. Then how do you confirm the diagnosis? Well, you could always use molecular, but of course not everybody has access to that. So we go to immunohistochemistry first. Easy, quick, and cheap. And here, I really recommend using these two biomarkers in combination. The first, of course, is the FH antibody, and you are looking for loss of FH to make the diagnosis with intact internal control. And then alternatively, 2-succinylcysteine is also overexpressed in these tumors. So there's now a commercial antibody to 2SC that we have, and you can see expression of 2SC in these tumor types. So the combination is really good to confirm this diagnosis. Now here come a bunch of pitfalls for you. First and foremost, the cytologic features that we see in FH deficient RCCs are not specific. This is a papillary RCC, FH intact, really high grade, large cherry red nucleoli. So those are not specific findings, they are sensitive findings in FH deficient. You also don't have to have those high grade nuclear features. This is a case that the patient had a kidney mass, young man, and a bone met. And this is the bone met. And it came to me with this cytomorphology, and I looked at it, and I'm a GYN pathologist, and I said, that's day 16 endometrium, except for it's a man and it's in bone. And that just doesn't make sense clearly at all. And he was a young man with a small renal mass and a metastasis. So I definitely think even with small renal masses, high grade tumors, and could it be something familial? So I just threw a dart and put an FH on this, and it was lost. So it's a good reminder that you don't have to have those cytologic features to be this diagnosis. Just think about the diagnosis in odd settings with pink tumors. Here's another tumor, an older male, 83-year-old male, clear cell cytology. This is like that slide I showed you at the beginning. If you looked at these first two images and you're a lumper, you're going to call this a clear cell renal cell carcinoma. Now, even if you're a lumper, you could consider, or if you're a semi-splitter, you could say, well, there's clear cell and eosinophilic and maybe some papillary or tubular architecture. Heterogeneity always makes me think about a translocation renal cell carcinoma, but those occur most frequently in females, young females, and this is an older male. So that doesn't really make sense. Quite certainly, I would want to exclude both of those entities. This was actually my colleague's case, and he did just that, showed it was a renal tumor with PAX8. CA9 is dead negative, so it's not a clear cell. And the TFE3 came back as patchy positive. And this you have to be careful about because it's a very finicky antibody. And unless it's strong and diffuse in every single cell, you want to go to molecular. You cannot call it if it's patchy, and this one was patchy. So I said to him, let's really look at this tumor. He sent the tumor off for TFE3 FISH. And in the meantime, I said, let's look at it closely. It had papillary architecture, eosinophil, and down here on the bottom, it's really, really pink. And again, it has the cystic formation, tubular and cystic formation, which always makes me think about FH deficient. This is all images from one tumor. And if you look in focally, you could see maybe some of these high-grade nucleolar features. So I said, you know, while we're waiting for the FISH, let's get an FH and a 2SC. And lo and behold, that's what this case was. So the point is, even in cases that you think have clear cell cytology that aren't the quintessential FH deficient RCC, you need to think about it. So this was an FH deficient RCC. Here's another pitfall. The FH antibody can be totally intact in 20% of cases. That's why I prefer to use FH and 2SC in combination. My fellow and I, Dr. Anderson, who's now actually on faculty with me, he and I did a study because we also had cases where it wasn't that it was intact FH, but it was patchy loss of FH. Some areas were intact and some areas were not. And so we thought, well, are these still considered FH loss if they're patchy loss. So we did a study and looked at as many as we could get our hands on, and we showed that those that had patchy F8 loss did in fact have missense mutations of the FH gene and were consistent with an FH RCC. So patchy FH loss, intact FH, plus the 2SC, you really have to consider an FH deficient RCC. The next pitfall, not all FH deficient RCCs are high grade. These were been described in a few recent case reports. Steve Smith reported one, but basically if you have a low grade, if I showed you this image here, basically you have eosinophilic, solid, and cystic findings. So certainly you should think about an ESC RCC if I had a case that looked like this, but it's not that big voluminous pink cytoplasm, and there's no basophilic stippling. There's some edematous stroma. You could think about oncocytoma here. A lot of low-grade renal oncocytic tumors could be in the differential here, but basically you have to think about it. SDH deficient RCC could also be in the differential. So you use these antibodies to exclude them, and by throwing on this cystic change made me think about it. FH loss, 2SC positive. This, in fact, and we did have molecular eventually on this case to prove that it was an FH deficient RCC. Just to prove to you that these can happen, here is a case, high grade on the top. This is a second mass below it, which is low grade. Here at higher magnification, high grade, low grade areas. Both areas were 2SC positive. Both areas had patchy FH loss. This was a patient who had multiple FH deficient RCCs, some of which had high-grade cytology, some of which had this low-grade cytology. What's important to remember is it's a little bit confusing because it's low-grade cytology, but it is still can be an aggressive plasm. And in the studies, it showed that most of these are associated with recurrence or associated high-grade FH tumors. So they shouldn't be treated like a low-grade. They need close follow-up, and they certainly need genetic testing. So to summarize for FH deficient tumors, poor prognosis if not detected early, will metastasize early. Think about them if as often as you can. If you find the FH deficient leiomyomas before an RCC, patient gets into ultrasound follow-up. That's really important. If an FH germline mutation is found, it's important for family members to be tested, and you have to consider this for both tumors with low-grade and high-grade features and heterogeneous cytology. My thing is, if you don't think about it, you won't make the diagnosis, so just try to think about it. The other thing is just to sort of distinguish it from those other papillary tumors. And again, this is sort of all in the setting of why we no longer are calling things type 2 papillary RCC. We're splitting them apart for a reason, and here's a really good reason. Patient care, and again, splitting these tumors apart allows us to consider clinical trials. This is a slide I borrowed from one of my colleagues here at the Dana-Farber, and this is combination therapy that was used in a study where they took so-called type 2 papillary RCCs, but were able to split them into FH deficient RCCs and papillary RCCs. And using this combination therapy, they actually showed that the FH deficient RCC patients did better on this combination. Here's the survival curve, 21 months versus 8 months. In the FH deficient RCCs, they did better than the papillary renal cell carcinomas. So if these tumors had all been lumped together as papillary renal cell carcinoma, maybe they wouldn't get this therapy and they wouldn't do as well. So it's really important so that they get the right therapy for better prognosis, especially in these lethal tumors. Okay, I think we're doing okay on time. The next one is the update on oncocytic tumors. And basically, I'm going to go over two entities that are in the emerging category because they're showing up in the literature all over the place. Of course, our classics are the oncocytoma and chromophobe. And if you're a lumper, this is pretty much all you're going to diagnose. But if you're a splitter, there's a whole nother slew of entities, which we can consider, again, two that we'll be talking about today. Oncocytomas have distinct morphology and chromophobes morphology, immunostaining patterns, and cytogenetic aberrations. Of course, we know CK7 expression in oncocytomas is usually single cell expression, and it's diffuse in chromophobe renal cell carcinomas, and both of these tumors are KIT positive. I'm telling you this because we're going to be talking about this in comparison to tumors like this one, which have mixed features between Some features that make you think about oncocytoma, round nuclei, oncocytic cytoplasm, and then some features that make you think about chromophobe, maybe a few scattered racinoid nuclei, but certainly some perinuclear halos. These can be nested or tubular, and you sort of like, I'm not really sure which one of these they are. Well, some papers have come out. Again, Kirill Tripkov's been really in the forefront of all this with these oncocytic tumors. And this new entity, which is still in the emerging category, is called a low-grade oncocytic tumor. Now, just cutting to the chase, these are benign. And if you're a slumper, if you're a lumper, you're going to say, why not just keep it with oncocytoma then if they're benign? But I'm going to hopefully show you reasons why they should be distinguished out. So they were originally referred to as CK7 positive low-grade oncocytic tumors. Again, these are indolent and considered benign. They occur, some say more in females, but it's a pretty equal ratio. And they have these morphologic features we're going to look at, but I showed you they lack a peripheral capsule. They're solid to nested to tubular. They have cytology that's overlapping between chromophobe and oncocytoma with these perinuclear halos, and you may see edema. The key difference with these tumors, they are strong and diffuse for CK7, which is more like a chromophobe, but they are KIT negative, which is wrong for oncocytoma and wrong for chromophobe RCC. So here's an example: tubular, small nuclei, maybe a few halos, strong and diffuse for 7, argues against oncocytoma. KIT negative argues against chromophobe renal cell carcinoma. They can show some Amicar and CD10, but it's usually patchy. Here's another example with more edematous stroma. Again, the edema may think you about oncocytoma, but has these weird perinuclear halos, CK7 strong, KIT negative. Here's a few pitfalls, and again, would make you think about some of the other tumors we've been talking about today: solid and cystic and eosinophilic. So ESC is definitely in the differential diagnosis with these. ESCs are also KIT negative, but they're typically 7 negative as well. And as I mentioned to you earlier, they should be CK20 positive. You could think about those low-grade FH deficient RCCs here, even a translocation, although I don't think it looks as much like that. But again, 7 positive, KIT negative is confirmatory for the diagnosis. Here's an example where it could have vacuoles, and vacuoles, again, are something that we look for in SDH deficient renal cell carcinomas. So solid growth, maybe some linear vessels, and these vacuoles, I would absolutely, and in this case, I said, this is going to be an SDH deficient RCC, but I did the SDH and I did the FH. They were both intact, excluding those diagnoses. And I put a 7 and a KIT on it. It was 7 positive, KIT negative, consistent with a low-grade oncocytic tumor. That distinction from an SDH deficient is clearly important. SDH deficients, RCCs are malignant and associated with familial situations, so germline testing is needed. Low-grade oncocytic tumors are negative. What I have here is on comparison for you is an actual SDH deficient RCC. In the inset, you've got one with vacuoles, just to show you that they don't always have vacuoles because tumors don't read textbooks. But in this case, the SDH was lost, confirming the diagnosis. So again, lots of morphologic overlap, but a handful, just 4 immunostains here help me make the diagnosis. Now, what do we know? And again, why do I think these are definitively outside of immunostaining? Why do I think these are different than low-grade oncocytic tumors? Well, there's been multiple studies that have come out. This one showed that if you did cluster analysis, the low-grade oncocytic tumors are in between but distinct from oncocytomas and chromophobe. And then the image on the right is looking at low-grade oncocytic tumors on the bottom compared to chromophobes on the top. And clearly the gene expression profiling is different. Multiple studies have shown now that these low-grade oncocytic tumors are associated with mTOR pathway mutations, either TSC1, TSC2, or mTOR itself. We actually have a paper in review right now looking at it from the other way around. Instead of just saying, here's a bunch of lots, what kind of genetics do they have? We took a bunch of unclassified tumors, 30 renal oncocytic tumors, and said, do we think they have the right morphology? And is the immunoperfect, i.e. all 3 criteria present, or one of those criteria is absent? And then we blindly looked at genetics, molecular rather. And if we took the ones, 15 cases ended up having features that were really good for lot, and 80% of those had mTOR related pathway mutations. In contrast, those that had weird morphology or an immunopattern that wasn't right for lot, only one case had an mTOR pathway mutation. So it really showed this nice concordance between lots and mTOR pathway mutations, and really confirmed that using 7 and KIT and excluding a couple of other entities is enough to make the diagnosis. But you should be careful of a couple pitfalls. For one, we had a case that was 7 positive, KIT negative, and it was pink and solid, as shown here on the right-hand side. And it turned out to have trisomy 7 and 17, which is consistent with a papillary renal cell carcinoma. So it was a solid eosinophilic papillary renal cell carcinoma. And one of our indeterminate cases had a loss of 3P. It was a so-called granular variant of clear cell renal cell carcinoma, ended up being CA9 positive. So again, the bigger pitfall to worry about is 7 positive, KIT negative is also a profile you can see in papillary RCC. So really you can use KIT and 7 and a few other biomarkers to kind of follow this algorithm to be able to see what you're to get to an entity, a diagnosis. All right, I am running a little short on time, so I want to get through this entity, eosinophilic vacuolated tumors. It is another emerging entity and has just that for morphology, eosinophilic and vacuolated morphology. The differential diagnosis is with all the other pink tumors and associated with TSC mutations, but majority are sporadic. They are thought to be small, indolent, and benign as well. So again, if you could say to me, why not just lump it together? Well, for one, the TSC mutation is different than some of the tumor types. And mostly when you look at these and see them at low power, you're going to think about a renal oncocytoma. They're nested, and here you might see that with an edematous to hyalinized stroma. And really, this case, I looked at it at first and thought this is an oncocytoma. But when you look closer, you can see there's solid growth, just like oncocytomas. They can have entrapped renal tubules, just like oncocytomas. But the distinction are these hugely vacuolated cells. And the more I looked, the more I saw them. They have very, very vacuolated. This is one cell, huge, enormous amount of cytoplasm in these vacuolated. And these cells have really, really big prominent nucleoli, which is unlike what we would see in an oncocytoma. So architecturally, they're very much like oncocytomas, but cytologically, they're very, very different. Here's some examples from Yingbei Chen's paper showing they can have vacuolization as well. So can we use immunostains to make the distinction? Well, they are different from oncocytomas and some of the other pink tumors. They are single cell scattered like oncocytomas, but they are KIT positive, which is also like oncocytomas. But distinct from that tumor type is the CD10 expression, and they almost universally have cathepsin K expression. So that in itself makes it different. The cytology makes it different. And again, as I mentioned, the TSC mutations, which we don't see in oncocytomas, makes them different. All right, so this is just an overview summary. I'm not going to go into it. You can look at all these pink tumors and sort of get a cheat sheet for your wall. You can also look at them here. These are like textbook summaries for each of these pink-like tumors of what you're looking for to help you out. And then this can be applied to certain cases. Really briefly, I'm just going to show you. These are 2 case types, starting with a low grade in a male, pink solid tumor, maybe has those perinuclear halos. You could say maybe this is a low-grade oncocytic tumor or one of the other entities. I applied a bunch of, I'm going fast because of time, I apologize, but you apply these immunostains, and basically I'm showing you over here and why all of these immunostains argued against all the diagnoses we were talking about today.
Interruption,
yeah.
Michelle. Just go ahead, do it slow, don't rush.
Okay.
We are recording this. If someone wants to leave, we will have the video for everybody. This is an extremely important issue, and I think that I don't want to jeopardize the presentation.
I'm very close to the end, but I will slow down on this. Okay, I appreciate it. Thank you, Paco. Okay, so basically what I'm saying is I have 2 cases here. These, I'm going to go over each one of them. One is on the left is a low-grade oncocytic tumor. The one on the right, you can see there's mitoses is a high-grade oncocytic tumor, and how would I approach them? So this is a 54-year-old male multinodular tumor here, which is a bit weird for some of these oncocytic tumors. No cystic spaces, solid growth, and again, you can see some of these perinuclear halos, maybe a slight amount of tubular growth as well. So many of the tumor types we've talked about today, but you can see here, absence of 7, 20, KIT. So it's not a lot without 7. FH was intact, SDH was intact, cathepsin is negative, so it's not an EVT, and basically excluded all of these additional diagnoses. So basically in a case like this where I'm uncertain, this I would call a renal oncocytic neoplasm, not otherwise specified, because I really couldn't get from morphology or immuno alone to a specific diagnosis, and it should fall into this NOS or other category. This is the second case. This was a middle-aged 48-year-old female. She had a renal mass and multiple metastases. A core biopsy had come from an outside institution who actually thought, based on the core biopsy, that it was an oncocytoma because it had this nodularity and edematous stroma. But there were mitotic figures in it, which was a clue. And then, of course, her multiple metastases makes it unlikely to be oncocytoma. All of her resections and the histology was extremely variable, high-grade nuclei, hyalinization, some clear cell, some cystic, and again, applied just about as many immunostains as possible as I could get. It was definitely renal with PAX8 expression, no 7, but had KIT. Okay, so it's clearly that would be an oncocytoma immunoprofile, but this is not oncocytoma. The absence of 7 argues against chromophobe, as does Amicar. Some CK20 raises the possibility of an eosinophilic solid and cystic tumor, but it didn't have any, as well as the cathepsin K, but I wasn't comfortable with this diagnosis. It didn't have the basophilic stippling, and frankly, ESC RCC should be negative for KIT, and this is a red reaction positive for KIT. We sent it off for TFE3, it was a young woman, and TFE-B fish, both were negative. So basically we excluded CA9, of course, was negative. I throw that on just about every if I'm unsure. And at the end of the day, I called this a high-grade renal cell carcinoma, unclassified type. It was sent clinically for next-gen sequencing and came back with a 2SC mutation. So it remained RCC unclassified, but had this 2SC mutation. Okay, so speaking of the mTOR and TSC mutations, this is my last point that I want to make, and that is that TSC mTOR pathway mutations do not define a distinct subset of renal tumors. If you've picked up on it throughout this talk, I've told you multiple subtypes, ESCs, LOTs, EVTs, also PEComas, also this unclassified RCC. All are affiliated with TSC mutations. So TSC mutated renal cell carcinoma should not be a top-line diagnosis. This is where I would rather not lump things together and again, split them apart. But it is just interesting to note that many of these new entities have TSC mutations. These are multiple references in regard to these tumor types that have been shown to have mTOR pathway mutations. And all these entities, this is this new edition WHO classification, all the entities listed as red have been described to have TSC mutations. So again, in my opinion, you should not diagnose a distinct TSC mutated renal cell carcinoma or tumor, but know that it is affiliated with other tumor types, and it helps understand why some tumors are split apart from things like renal oncocytoma and chromophobe. All right, to summarize what we've talked about, I hope that now you have a better understanding of the WHO classification of renal cell tumors. Note that the clear cell tubulopapillary tumors are no longer a carcinoma. We are no longer typing papillary renal cell carcinoma, and understand that there's this whole new group of molecular defined renal cell carcinomas, including these genes, but not TSC or mTOR as a discrete entity. And then, of course, we're still learning about more tumor subtypes. Beware of overlapping morphologic diagnoses and diagnostic pitfalls. Take away this idea, again, whether you're a GU pathologist or a lung pathologist or a neuropathologist, this idea of slumper and that we should be thinking of things. Neuropathology is one of those areas where they've really used molecular to split things apart. And I think so, again, it's across systems, but I think it's an interesting concept of what we do on a day-to-day basis. Why do we do all this? Of course, for patient care, it affects prognosis, genetic workup, treatment options, clinical trials, and then I always joke around for my job security. With that, I thank you very much.